Welcome, everyone. We've got a great group on this legislative briefing this afternoon. We'll be talking about non-medical switching, for which we have two bills filed in the Texas Legislature this session that would address the issue of non-medical switching. So my name is Greg Hanch. I'm the Executive Director of NAMI Texas, which is the Texas affiliate of the National Alliance on Mental Illness. And I also help to facilitate the Coalition for Stable Patients, which I'll provide an introduction to in just a moment. So thanks again for being here. So you may ask, what is the Coalition for Stable Patients? Well, it's a group of organizations that attempt to pass legislation in Texas to address the issue of insurers making cost-motivated decisions that switch patients or restrict access to patient medications that patients need to maintain their stability and recovery. And we'll explain in sort of greater detail what we mean by switch patients off of medications. But the coalition aims to strengthen patient protections so that insurers are less able to restrict access to medications that they have previously approved and that are working well and effectively for patients. So you can see on the slide here the organizations that are a part of our coalition. And these are just the organizations that are formally signed on to the coalition. And apologies in advance if I missed anyone. The list has been growing rapidly. We've been adding new organizations all the time. But I think what you can see here, as a little bit of a cross section of the patient advocacy community, is there is really broad support for reform on the issue of non-medical switching among patient advocacy groups and provider advocacy groups. And when you look at the witness list of the bills that we've advocated for in past sessions, there's nearly universal support for non-medical switching reform across patient and provider advocacy communities. So what we, as I mentioned, are working on, and our purpose is to protect patients from non-medical switching. So it stands to reason, but I'll just say it anyway, that patients with chronic and complex diseases often require medication so that they can do their jobs, care for their families, and participate in their communities. Medication for many people is the cornerstone of their ability to function and be involved in their communities and in family life. Without ongoing access to medication, their symptoms will often progress so severely that they're unable to engage in a normal and healthy life. So finding the right medication is really kind of the first step. And that is often not easy. Patients walk a long path and come up against many obstacles in many cases to find the product that works best for them. There's no one-size-fits-all medication. What works for one patient with a specific chronic condition may not work for the other. So there's a long journey just to find that right medication in the first place. That's step one. And then after you get that medication and receive access to it, unfortunately, you will often then encounter barriers along the way that restrict your ability to keep that medication. And remember, these are chronic conditions, so the ability to manage those chronic conditions depends upon ongoing access. Ongoing access is affected by the insurance industry's cost-motivated tactics to move people away from medications that are working well for them and that were previously approved by that very same health insurance plan. So the insurers will often force patients to abandon proven treatments for cheaper alternatives, and that is what's known as non-medical switching. By the way, if any questions come up from any of the attendees, please drop those into the Q&A box, and we would love to address any questions. So you may ask, how does this occur? What does non-medical switching look like? So health plans may price patients out of their prescribed medications by assigning the medication a higher copay, meaning that the patient has to pay more out of pocket. And for many people, having to pay more out of pocket means they're not going to be able to afford and therefore access their medication anymore. The second bullet point is quite similar, increasing the patient's out-of-pocket requirements or moving the medication to a higher cost-sharing tier. Health plans will also, in some cases, reduce the maximum plan coverage amount, so they'll only cover up to a certain dollar figure for a medication in a given year, and once that dollar figure is exceeded, then the patient is out of luck and will have to pay out of pocket to continue to access that medication. And for many people, that's just not an option. Also, health plans will sometimes eliminate coverage for medications entirely. They'll move the medication completely off of the formulary, which means the plan won't pay for that medication anymore. And because many patients won't be able to afford it out of pocket, the patient no longer gets access to it. These are all forms of non-medical switching, among several others, that affect patients' ability to keep accessing the medication that works best for them. I don't know why it's doing that. So you might be wondering, like, what types of patients or what disorders are affected by non-medical switching. This is certainly not an exhaustive list. These were kind of the ones that came to mind for me in looking at the literature. These are all, you will hear from patient groups among all of these disease states who are affected by non-medical switching. And each of the advocates in these groups have seen people who have suffered as the result of losing access to their medications because of the cost-driven decision made by a health insurance company. So, you can see some of these diseases are quite severe. Some of them are life-threatening. All of them, if not properly managed, will affect quality of life and affect a person's ability to fully engage in a healthy and productive life. And I suspect, everyone on this call knows someone who has been affected by one or more of those conditions. And if we know someone who has been affected, we probably know how important it is that the individual that we know and that we love continues to get access to the treatment that works best for them. So this is an issue that affects a lot of people personally. Either they themselves are the patient, or they have a friend or a family member who has the condition and needs ongoing access to the right care at the right time. So I encourage you to, identify what on the slide have you seen people in your life affected by, and how important do you think it is that the individual that you know and love has access to care. With that, those were kind of just the introductory remarks, just to set a kind of a high level framework for the issue of non-medical switching and how people are affected by it. We will get further into detail about the specific negative impacts of non-medical switching. We'll share some stories, and we'll also share some data points that indicate how severe the issue of non-medical switching is in the state. But first, we're very fortunate to have State Representative Stan Lambert on this webinar with us. State Representative Lambert has championed the issue of non-medical switching reform over the last couple legislative sessions. Representative Lambert serves in House District 71. He's from Abilene. He's in his third term in the Texas House. And he represents 3 counties in the greater Abilene area, including Taylor and Jones. State Representative Lambert filed HB 2099 last session, and wow, did that bill get some momentum as the session progressed. More than 1/3 of the House members were co-authors or joint authors on the bill. That's remarkable. You rarely see that many people signed on to the bill before it comes to a vote. And we'll get into the specific numbers later, but it passed the House by an overwhelming majority on both second and third reading. And this session, State Representative Lambert has filed HB 1646, and Senator Zaffirini, who we're also very grateful for, has filed the companion bill, SB 1142. Representative Lambert, if you're on with us, we would kind of love to hear from you on your interest in this issue and why you think it's important that the legislature address non-medical switching in this legislative session. Thanks, Representative Lambert.
Thank you, Greg, and it's good to be with you this afternoon. You've already kind of given the real details of the bill numbers and the history that was in the 86th legislature last session, overwhelmingly passed in the House. As you mentioned, quite a record number, or a very large number of co-authors and co-sponsors for this bill. Just kind of didn't get much movement, or any movement really, in the Senate. And so that's part of the strategy in this session, is to ask Senator Zaffirini to champion this bill in the Senate, and to try to see what we can do to get some similar momentum built on the Senate side, because I really believe that we'll have very similar, very positive votes on the House side. So it's really the same bill. It's something that's very important to our constituents, not just in my district, but throughout the state. Maintaining a stable treatment plan is extremely important. We know that sometimes these formularies and the medication challenges, it takes months, sometimes years, to really get to a combination of different medications that a person may be needing in order to address their chronic illness or their particular medical issue that they're challenged with. And so for no other reason other than just trying to increase profitability on the healthcare plans, we see, and I see, that the challenge is trying to pass legislation that would allow patients to remain on a stable treatment plan that is physician prescribed. Sometimes the health plans, they don't call and ask the physician, what do you think about moving this person off this particular drug to this drug? And so sometimes it just happens really without any consultation with the patient or with the patient's physician. And so we just believe that this demographic, these folks that need these stable medication plans, need to be able to have access to staying on those plans once those treatment plans get stabilized, and once they are getting the help they need. And as Greg mentioned, just to be able to continue with their life, to be able to continue to go to work, take care of family issues and so forth. The cost of not doing that are extraordinarily high, because once those changes do get made arbitrarily, without consultation, without physician involvement, then there's a period of time when the patient could possibly go backwards in terms of their overall medical and health condition, and sometimes may end up back in the emergency room, or may just having to deal with that issue, whatever it is, involving their health plan at these annual renewal periods, just makes it a very difficult time for them. So the additional cost of their health care, as well as the time that's lost after getting on to a stable treatment plan and a medication plan that works and is physician prescribed, just doesn't seem like a very smart thing to do. It just doesn't seem like it seems like we can come up with a better solution. And so for me, that was the impetus for me to get involved. I served on the insurance committee in the last legislative session, where this bill actually came through that committee and passed out, and then went to the House floor. it will go through committee again, and most likely will go through insurance again. So we're ready to move forward and try to see what we can do to get this accomplished in this session with Senator Zaffarini's assistance. So looking forward to continue to work on this and try to get as many of my fellow members and colleagues to sign off on this. And so if you've got representatives in your area of the state, it would be great if you would encourage them to co-sponsor 1646 on the House side, and we would appreciate that support. Thank you, Greg.
Well, thank you very much, Representative Lambert. And we just, can't express our gratitude enough for how hard you've worked this bill over the last couple of years, and how well you explain it. We can tell this is something that you care about, that these vulnerable Texas patients matter to you, and you want to do what you can to make a difference for them. So thank you again for your leadership on this, and we're very pleased to be working with your office once again to advance this very important bill.
Absolutely. Thank you. Let's get it done this session.
Absolutely. So with that, we're going to move on to our next session, which is a panel. Very exciting stuff. I'm thrilled to know each of these people and have worked with them, some for longer than others. But they all have very meaningful stories to tell on the issue of non-medical switching. And we wanted folks to hear from different perspectives here. We wanted people to know what it's like to be a patient and to have been affected directly by non-medical switching. We wanted also folks to know what it's like as a healthcare provider and the frustration that you experience and the negative impacts that you see that your patients suffering as the result of non-medical switching. Providers and prescribers have a really valuable perspective to share because they have a direct window into what this looks like and what the impact of it is. And then finally, we wanted to hear from a family member who has seen the direct negative impact of non-medical switching and can speak to what impact that has had on them personally as well as on their family. So we have Chase Bearden with Coalition of Texans with Disabilities. And I'm going to let the panelists kind of introduce themselves rather than kind of reading their bios. We have Dr. Kevin Finkel, and we have Ann Grady. And it's really kind of an open-ended discussion. I wanted just to give each of them the chance to share their stories about what they've seen when it comes to non-medical switching, what impact it has, if you have any thoughts on how it should be addressed, without getting too far down the path of talking about the legislation, because we'll cover that later. If you would, Chase, first, if you would talk about your perspective on non-medical switching and how it's impacted you, and then we'll go to Dr. Finkel.
Yeah, Greg, thank you. First, I'd like to say thank you to Representative Lambert for all his years of working on this issue for all of us. Again, my name is Chase Beard, and I'm with the Coalition of Texans with Disabilities, a statewide advocacy organization that focuses on cross disability. And I can tell you, our membership specifically has run into this issue at different times in their lives. For many of them, usually the one thing that we like to talk about when we're talking about creating a healthcare system that's affordable and helps everyone. And one of the key words we always talk about is just stable patients. The most cost-effective healthcare system is one that puts the patient first and keeps them stable. When we talk about non-medical switching, it basically does come down to a practice where once you are stable on a medication that no fault of your own, it's being swapped on you. And I think for many of our members, I myself, I've been in a wheelchair now, gosh, since I was 17, going on 27 almost years. I've dealt with some chronic health issues because of it. I know many of my family members have too. And it's not sometimes just taking one medication that keeps you healthy and keeps you working. It's 5 or 6 medications that you're on the rest of your life. And when you find that balance between those medications, you're able to put the medical concerns of your life to the side and focus on what really matters: your family, your friends, going to work, being a very, successful part of our community. And to do that, you have to be healthy and you have to feel good. You shouldn't be worried along with your family members on if you're going to be able to get the medication you need. I don't think those that haven't lived through dealing with a chronic health issue that really requires a regimen of medications will truly understand how difficult it can be, just trying to manage all of that. And when you look at the disability community, you're already having to manage just making it to the pharmacy on time, transportation issues, getting to the doctor. And you really do want to keep that patient doctor. They're the ones who are working through these issues at the heart of it. Not a decision being made by a healthcare company who's looking to put guardrails on how doctors prescribe, or just catching you completely off guard. And you usually don't find out until you're at the counter in the pharmacy. And that's when you have to make a decision. Do I pay $2,800 today that I did not know I was going to have to pay, or do I not take the medication? Well, most people don't have $2,800 to pull out of their pocket. Yesterday, we ran into that problem even with my wife. As our new plan year has started, we went to the pharmacy to pick up a medication she's been on for years that has always cost us $50 a month to be able to get her the medication she needed, to find out that they had now changed the way our plan works. Now, as a reminder, I've been in the same Blue Cross Blue Shield plan since 2009. We have not left that insurance company. But we found out that our pharmacy benefit had been moved into our deductible. And so we no longer pay a copay. Instead, you pay it all up front. You have to pay out your out-of-pocket and deductible out front at the beginning of the year yourself. And then medications will start costing less towards the end of the year. This was in no way communicated to us. And that's a pretty significant change. And as I was on the phone yesterday with Blue Cross and the people that handle the pharmacy benefit for them, I asked them blatantly, what do we do if we can't afford the medication this month? And their suggestion was, call your doctor and change your meds. So really, it came down to a medication that there is no generic for, but they've got us having to figure out how do we pay this off, and put us in a position where you don't have much time to decide. So now you have to look at drug adherence. How many people are going to not take that medication? I mean, we have to make the decision over the next few days to put that on our credit card and figure out how to pay that down. So it's little things like that. It's ways that insurance companies look at utilization and then find a way to reduce their cost, not the patient's cost and not at the overall healthcare cost. So I know for our members at CTD and in Texas, putting the patient first and the doctor first in making these decisions is how we have a healthier Texas. Thanks, Greg.
Well, thank you, Chase. A very powerful story. I think it explains the issue so well, and gives us a feel for the dynamics behind it and how different players are involved with it, different stakeholder groups are involved. And you, as someone who has been personally affected, I feel for you in that, because that can't be easy. And this is a great example of a case that gives us that insight into why we know this issue is so important and needs to be addressed in this legislative session. I'd like to now turn to Dr. Finkel to hear his perspective as a physician and as a prescriber.
All right, thanks, Greg. First of all, let me introduce myself. I'm Dr. Kevin Finkel. I'm a professor of internal medicine, and I'm also the chief of the Department of Kidney Disease at McGovern Medical School in Houston, one of the UT schools. And the reason I'm involved with this is my patients are incredibly complex. And so they are affected by this non-medical switching. Just to give you a perspective, if you have kidney disease, you have multiple organs also involved. So they almost all have hypertension. They have heart disease. They have vascular disease. They often have autoimmune diseases like lupus or rheumatoid arthritis. So the typical kidney patient is on 9 medications. That's the average amount of medications, is 9. So you can imagine, if my goal is to try to make the patient feel well so that they can participate with their family, they can work and pay their taxes, and they're not using high cost medical care like the emergency room or being hospitalized, or worst case scenario, lose their kidney function and go on dialysis, which is incredibly expensive. So it takes me weeks to months with my patients and their families to come up with some kind of medical regimen where I have to worry about drug-drug interaction and making sure that they feel well. And when we come up with a treatment plan that has stabilized them and they're working and they feel well and they're not going on dialysis, and then all of a sudden it's January 2nd, and then I get called a week later saying that they're in the emergency room with high blood pressure, a stroke, they're in such severe kidney failure that they're now going to go on dialysis, and I find out that one of their medications they were just priced out of as of January 1st. So that to me, I see this, unfortunately, it is not infrequent. So that's why I got involved. And since I have a couple minutes, I just want to tell you about one patient I have, because she's really dear to my heart. So her name is Ebony. She's 34. I've been taking care of her since she was 17. When she came to me with heart problems, seizures, joint problems, and kidney failure because she had lupus. And at 17, she couldn't go to high school. She wasn't going to graduate because all she was doing was being in the emergency room or being admitted to the hospital. So I started on a medication that the insurance company paid for, and it was actually relatively cheap. The problem with that medication was it makes you sterile. So I had to tell this 17-year-old girl that she's never going to have a family or a child. The second is it works, but if you give it long enough, it's a carcinogen. And so if I continued to give her that medication, I was going to give her cancer. So you scramble around after 3 or 4 years and you hit on another medication. It's more expensive, but the insurance company pays for it. I started her on it. She did very, very well. She was having some breakthrough problems. So finally, after 15 years, I got her on the most recent medication, which is expensive. The insurance company was paying for it. It was an injection that you got 4 times a year. And so she actually got her GED. She went to junior college. She became an LVN. And she looked better than I'd ever seen her over the 10 or 15 years that we were going through this process. Nothing changed for her. She was working, her insurance didn't change. And then her mother calls me, this is about a year ago, her mother calls me and says, well, she's in the hospital in the emergency room. She's seizing, and her kidney failure is so bad that they're putting her on dialysis. And my first thought was, oh, I wonder if the drug's not working anymore. Well, it turns out that when she showed up for one of her injections, the price had quadrupled. It was something like $1,600 pay up front. And so what they did, which with what a lot of patients do, is they'll ration their medicines. So they'll go twice a year instead of 4 times a year. So this whole process that we went through, where we kept her off of dialysis, she was working, she was happy, she was healthy, was all destroyed by somebody wanting to change the price of a drug. And so to me, this bill is about protecting patients and being good for patients. And if someone's against the bill, the question should be, well, if you don't pass the bill, how does that help the patient? And that should be the only question about this, is what helps the patient. So that's why I got involved, and that's my perspective.
I love how you center the patient in the conversation. I mean, what should be our North Star for policymaking on healthcare? It should be what's best for the patient. Is it better for the patient to be protected from non-medical switching, or is it better for insurance plans to have the ability to switch things up on patients? I think there's a pretty, obvious answer there in terms of what has the most positive impact on the lives of patients. And also, I just want to note, both in Chase's story and in Dr. Finkel's, their stories, and I think the third one will as well, point to how non-medical switching facilitates the inefficient use of scarce resources in the healthcare system. You make these short-sighted, cost-driven decisions to restrict access, and you end up paying for it down the road and then some. There's added cost. People, Dr. Finkel's folks, are ending up on dialysis when as a result of non-medical switching. Folks are ending up hospitalized in the criminal justice system in the case of mental health. So these are all important considerations. We can't just look at it through this narrow window of, well, what's the cheapest medication? Wouldn't the cheapest medication lead to the lowest overall spend on healthcare? In many cases, not. Probably in most cases, not. So that's something for, I think, just a lens through which to think about this issue. And I want to introduce our last panelist, Ann Grady. I've had the chance to get to know recently, have seen her speak on occasion, and she tells her story and her family story extremely well. I came to learn recently that Ann's family has suffered dramatically negative consequences as the result of non-medical switching. And I wanted to ask Ann to kind of explain what that has looked like for them, what impact it has had, and why they think it's important that the legislature address the issue of non-medical switching right now. So Ann, thank you so much for being here, and we're looking forward to hearing from you.
Thank you, Greg. And thank you, Senator Lambert, for your support of this bill, or Representative Lambert. So my name is Ann Grady. I live in Round Rock, Texas, and I'm an active member of NAMI Alliance the National Alliance on Mental Illness in Central Texas. It's part of America's largest grassroots mental health organization. When my son Evan was born, I knew something wasn't right. He was cranky and irritable and inconsolable. And I began therapy for him when he was just 11 months old. When he was 2, I was told it was a matter of when, not if, he would need medication. When Evan was 3 years old, he tried to kill me. And by the age of 4, he was on his first antipsychotic. Evan will be 18 next month, and he has been on over 50 psychiatric medications and hospitalized 3 times. Most recently, just a couple of weeks ago in February, because our insurance company, Blue Cross Blue Shield, refused to cover his medication due to its cost. Finding the right medication has been next to impossible. And the few times that we were on track, our insurance denied it because of the cost. And every single time it threw Evan into a tailspin. This time, our medication and the bill that we got last month was for $2,480. And that was just for one of Evan's medications. He's on 5. After trying several less expensive medications, Evan became unstable. He hurt himself. He assaulted his therapist. He threatened to kill himself. He threatened to kill several other people. And this is the 4th time and the 2nd insurance company that has denied treatment due to the cost of medication. Prior to COVID, 1 out of every 5 adults and children suffered from mental illness. And since COVID, that number has jumped to 1 in 3. No one should have to choose between their own health, the health of their child, or someone that they love, because medication that has been working is no longer covered by insurance. I'm here as a parent, as a resident of Texas, to ask you to please put an end to non-medical switching. Causing someone to abandon a therapy that is effective for one that is less costly is not only wrong, it is life-threatening and immoral. While it may seem to make sense in the short run for insurance companies to maximize their profits, the results can be catastrophic. Because of Evan's medication switch, we have incurred thousands of dollars in hospital and pharmacy bills, and Evan ended up hurting himself and others. If we weren't able to pay out of pocket to get Evan the treatment that he needed, he'd most likely end up in the Texas jail system, which is the largest provider of mental health services in the state. The issue of non-medical switching is one that affects many Texans, especially those with chronic illnesses that require daily medication or multiple medications. These patients rely on these medications to be productive members of society, and access to these meds help them avoid trips to the emergency room, helps protect them from having to obtain other more costly forms of care. I'm asking that insurance companies be required to continue medication that is working regardless of the cost. It ends up saving hundreds of thousands, if not millions of dollars in the long run. And it's the right thing to do because it saves lives. I appreciate the legislative committee for their attention to this issue, and I'm hoping that I can count on your support for House Bill 1646. Thank you for allowing me to be part of this meeting. Greg, back to you.
Thank you so much, Ann. Such a powerful story. And, you know, as a mental health advocate, and I've worked on mental health now in the Texas Legislature for 5 sessions, and, you know, it's worth noting how much progress has been made on mental health, and how each legislative session over the last decade has really, you know, taken it up a notch in terms of what our legislature has done to address mental health. It's a priority of many, many people. But we still have a long way to go. And this is one area that hasn't gotten the attention and action that it needs, especially considering, you know, one, how we're seeing an increased demand for services like we've never seen before, as a result of COVID and other factors. And then two, how important medication is to a recovery plan for a person with a mental health condition. You know, there are many mental health conditions that medication is absolutely essential to treat, and the other services for mental health won't have the impact that they're intended to have without mental health being part of the treatment plan. So the fact that there are people with mental illness who are losing access to medications that are working well for them is completely unacceptable, and it's inefficient, and something needs to be done about it. So thank you again, Ann, for being here with us today. We're now going to turn to a couple subject matter experts who are going to share some insight into the consequences of non-medical switching on the healthcare system and on the economy.
Well, thanks, Greg.
Yeah, sorry, go ahead, Derek.
Thanks, Greg. My name is Derek Flowers. I represent the Alliance for Patient Access, and we are a physician-led nonprofit that focuses on policy as it relates to patient-centered care. And of course, non-medical switching is something that a lot of our clinician members are talking about, and something that we've engaged on at the state level. I want to share with you some information that that we found as we looked into how big of a problem this really is, and what does it mean for patients and the healthcare system on the whole. So as you heard from the 3 previous panelists, it can be disastrous for patients, but it can also be disastrous for the healthcare system. So in 2017, the Institute for Patient Access, which is our sort of our think tank arm, undertook an analysis of commercial insurance claims to explore the financial impact of non-medical switching. And what we found, as you might expect, is that the tactic drove up non-drug costs for the healthcare system. That is, in other words, complications from the switch led patients to seek more physician appointments. It led to hospitalizations, ER visits, lab tests, et cetera, all things that drive up healthcare spending. Meanwhile, the patients who stayed on the medicine that worked for them, the one that they and their physicians selected, they had the lowest per month costs for the insurer. So that study, if you're interested in looking, is available at instituteforpatientaccess.org. You know, I want to be careful with the conclusions we draw, but it was about a 3.9 million sample study. And I think the key takeaway here is that lower spending for insurance companies on prescription drugs doesn't necessarily lead to lower costs for the overall healthcare system. Next slide, Greg. And so then to follow up that quantitative analysis in 2019, we did a study looking at the qualitative impact of non-medical switching. That is, what happens to patients? How do they feel? And what are the consequences of non-medical switching beyond just the healthcare implications? And so in this instance, what we found was that their mental well-being, their quality of life, all were impacted. To explore the question, the data we found, we have a 2-minute video that really summarizes the findings, and we'll share that with you now. Go ahead, Greg.
Health insurers want to boost profits by switching stable patients to a cheaper medicine, but their efforts are having a painful effect. A national poll surveyed patients whose insurers had switched their medicine for arthritis, diabetes, migraine, epilepsy, or another chronic condition. 60% said it had been hard to find a medicine that worked for them. 75% of patients had anxiety, they said, about losing the medicine they depend upon, and with good reason. Patients reported the new medicine was not as effective as the original. They had complications, like new side effects or re-emerging symptoms. And 1 in 10 discovered that the new medicine interacted with medicine they took for other conditions. The symptoms weren't just medical. Problems related to the switch undermined people's ability to focus and be productive at work. More than half said they could no longer enjoy hobbies or activities in their free time. And 43% said they couldn't care for children, spouses, or parents like they needed to. So it's little wonder that non-medical switching left patients feeling frustrated, confused, and even helpless. A woman from Texas with rheumatoid arthritis said it was a nightmare. A man from California with diabetes said, "I couldn't sleep." And a woman from Oklahoma with chronic pain said, "My depression got worse." So, given everything that patients went through, did these switches actually save the health plan's money? Hardly. 40% of patients had to visit their physician more often after the switch. Nearly a fourth of patients had to make appointments with specialists. 22% needed lab tests, and nearly 1 in 10 had to be hospitalized. National research makes it clear. It's time to put patients' well-being ahead of health insurers' profits. It's time to end non-medical switching.
Thank you, Greg.
Thank you, Derek. And now we'll hear from Brian Nyquist.
Thanks, Derek. Thanks, Greg. Good afternoon, everyone. I'm Brian Nyquist. I'm a former policy analyst for the House Committee on Public Health, and I'm currently serving as leadership of 2 national nonprofit organizations. I'm president and CEO of the National Infusion Center Association and executive director of the Infusion Access Foundation. Across these 2 organizations, we support patients that require provider-administered medications to manage complex chronic diseases and the providers that care for them in safe, more efficient, more cost-effective alternatives to hospital care settings. So as we've covered, forcing medically stable patients to change medications for reasons unrelated to health or safety carries significant implications. Now we'll look at some of the broader economic implications, starting with data from a 2020 Avalere study. Next slide, please. So looking at Medicare patients, Avalere found that medically unstable patients cost more than twice what it costs to manage stable patients because they consume more hospital outpatient services, more physician services, and are hospitalized much more often. Since healthcare is generally at least twice as expensive under commercial insurers, these cost differentials are even greater for medically unstable patients that are commercially insured. Next slide. So why do medically unstable patients cost more than stable patients? In general, it's harder and much more expensive to improve poor health than it is to maintain good health. Think about regular maintenance for your vehicle. You do regular oil changes. It's a lot easier and less expensive than replacing your entire engine. Next slide, please. So how does non-medical switching impact employers? Well, medically unstable employees must take more time off of work for medical emergencies, for doctor appointments, imaging, testing, etc., resulting in lost productivity. This lost productivity may contribute to missed deadlines, increased workload for colleagues, and adverse impacts to organizational culture. Employers may need to also hire temp workers to keep these projects on trajectory, requiring additional investments in onboarding temps, as well as adding to overall project cost. If the employee is covered by a self-funded employer plan, their increased healthcare consumption directly increases the plan's cost burden and risk. To offset this increased cost and risk, underwriters will target coverage reductions to reduce cost and/or premium increases to offset increased spend in subsequent plan years. These catalysts initiate downstream changes with broader economic implications like program budget cuts to offset increased healthcare spending, reduced coverage in subsequent plan years, increased premiums, and employee turnover due to layoffs to cut costs, or resignations because employees are just so frustrated that their medications that were covered in previous years no longer covered and they've become medically unstable. In the end, the increased burden is spread across all employees. Next slide, please. So without transparency, the economic implications for insurers are much more difficult to drill down. What we do know is that health outcomes are poor despite an increase in healthcare consumption and increasing the burden on patients and their insurers. But insurers tout non-medical switching as a critical cost containment strategy despite the evidence to the contrary. If non-medical switching was an effective cost containment strategy, we would expect to see certain indicators supporting that notion. However, looking at the claims data, any immediate term cost savings are heavily outweighed by the long-term increases in healthcare spending, patient out-of-pocket costs, and the implications to the physical, emotional, and economic burdens of disease. These economic implications are particularly profound in the commercial insurance market. Next slide, please. So some questions to consider. Do forced medication changes for reasons unrelated to health or safety constitute the practice of medicine? Is forcing medically stable patients to change medications, again, for reasons unrelated to health and safety, morally acceptable to the state of Texas? If this strategy is effective at containing costs, shouldn't we expect premiums to remain the same or decrease year over year? And finally, is it possible that these forced medication changes are profitable for insurers after spreading risk across beneficiaries? Next slide. To quote the 1984 Nobel Peace Prize awardee Desmond Tutu, hope is being able to see that there is light despite all of the darkness. When patients achieve a state of medical stability, they have finally found light at the end of their long, dark, and arduous disease management journey. The prospect of being able to remain medically stable is a source of hope to be able to continue working, retain the function of their hands, play with their children, or enjoy basic aspects of life that the general population may take for granted. To have that hope ripped away for reasons unrelated to health or safety has debilitating implications on the physical, emotional, and economic burdens of disease for some of our state's most vulnerable citizens. Without statutory protections against non-medical switching, these patients will lose their source of hope and be forced to start from scratch every plan year to find a plan that provides adequate coverage for their medication. Now I'll hand it back to Greg to speak on how House Bill 1646 would address non-medical switching. Thanks, Greg.
Thank you, Brian. So here is our sort of call to action leading into the action that we're hoping folks on this webinar will take. You may ask, how can lawmakers protect patients? We can pass these bills, both Representative Lambert's bill or Senator Zaffarini's bill, to keep stable patients on their medication by requiring that health plans and third-party payers maintain coverage for patients if the medication continues to be prescribed by their doctor for an ongoing condition. So the physician, in consultation with the patient, determines what the best course of treatment is. And two, if the medication has been covered by that same health plan within either the current or a previous plan year. If the patient keeps the same plan, they have the ability to keep the same medication. So it's really quite simple. It's not a complicated bill. Same patient, same plan, same medication, if that's what the physician or the other prescriber determines is the best course for the patient. Why do we need these existing protections? Well, it's because if protections against non-medical switching only apply for a single coverage year, patients risk losing access to their medication each and every year they stay within the same health plan. There's always going to be a risk that a patient might no longer be able to access that medication because their insurer has switched them off of it. And that's despite the reality that the need for treatment will often continue indefinitely. If there's still a need for treatment, then a patient should continue to be able to access that treatment. We do have in Texas a protection against non-medical switching within the plan year, but we don't have the year-to-year protection. The within the plan year protection has been in place for 10 years, and now is the time to strengthen it and take it to the next step to provide additional protections for patients. Once a patient is stabilized on a treatment and health plan coverage for that treatment is secured, that patient should have the right to continue for as long as that patient stays within that same insurer. This bill does not address if patients switch between different health plans or different insurers. And I just want to drive that point home a little further of what the existing protections do not do. The existing protections do not protect a patient who keeps the same health plan from one year to the next unless the switch mechanism is step therapy. And folks may be familiar with the step therapy protection that was put in place in 2017. There is a section of that legislation that addresses non-medical switching in a very narrow and limited way. Patients are protected from one year to the next if the switch mechanism is step therapy. But if the switch mechanism is anything other than step therapy or fail first, then the patient has no protection whatsoever. So patients are not protected from removal of the drug from the formulary. Patients are not protected from new prior auth requirements. Patients are not protected from new quantity limits. Patients are not protected from being priced out by higher cost sharing requirements or copays. And patients are not protected from lower coverage limits. So these are the things that the bills that we're advocating for would address. I want to make clear on this point what the legislation would not do, because there can be some confusion about what the provisions of the bill would actually apply to. So health insurance plans still have the ability to make favorable changes that improve patient access. Unsafe and ineffective drugs can still be removed from coverage by the health insurance plan. The bill does not require ongoing coverage of unsafe or ineffective drugs, or if the FDA takes away approval for the drug, it can still be removed from coverage. The bill does not prohibit generic or biologic substitution. That's an important section of the law that this bill explicitly does not undo. The legislation does not affect when a new enrollee, so a brand new customer to a health plan, this bill doesn't have any impact on them. It only has an impact for that new enrollee if they keep the same health plan the next year. The bill does not affect the provider's relationship with the patient. In fact, it really kind of solidifies and strengthens the provider's relationship with the patient. We need to be putting trust in our healthcare providers and prescribers to determine what the best course of treatment is for the patient. And so this legislation really kind of centers that relationship between the prescriber and the patient, and that is critically important. Healthcare decisions should be driven by healthcare professionals. The provider's prescribing authority remains intact. The bill does not affect that in any way. It doesn't require a prescriber to prescribe anything. That authority, that discretion is preserved by this legislation. And the bill, importantly, does not pertain to Medicaid, TRS, ERS, or self-insured plans. And the piece about it not pertaining to self-insured plans is a new addition to this bill that we decided would be important to add, because there was some confusion last session that the bill would pertain to plans that are self-insured, and there was concern about that. So we explicitly indicated in the bill language that this bill would not affect self-insured plans, and we expect that that change will mitigate some of the opposition that we encountered in the last legislative session. So with that opposition being mitigated, it seems to me that the only opposition we are likely to see to this bill would be the health insurance industry itself and the pharmacy benefit managers that health insurance companies work with. As far as patient advocates go and provider advocates, I think we see, like in the last session, we see nearly universal support. The bill only affects fully insured health plans regulated by the Texas Department of Insurance. Just a little bit of quick legislative history before we wrap up. I know we covered some of this previously in the presentation, so I won't spend much time. I think, most notably, I want to just mention this is the third session. We've been working on this. We've made more and more progress each session. In fact, in 2019, the bill not only made it out of committee for the first time, it also passed the House for the first time by, as we mentioned, an overwhelming majority on both second and third reading. Also of note, the bill was heard in public hearing in the Senate Committee on Business and Commerce for the first time last session. So momentum has been building, and now is the time for further action to be taken, especially with new vulnerabilities exposed by the COVID-19 pandemic. Patients need ongoing access to care now more than ever. This is actually the last slide. And I do want to just say a quick call to action, because I know we have a lot of legislative offices on this webinar and other folks in the Capitol. My call to action would be for a legislative office, please sign on to the bill. Whether your office is on the Insurance or Business and Commerce Committee or not, we want to show as much support for the bill as possible before it hits the floor. So if your office would please consider reaching out to Representative Lambert's office if you're in the House, or Senator Zaffarini's office if you're in the Senate, and indicating your support for this bill that would protect vulnerable patients, we would really appreciate that. And that's a potential next step for you. Additionally, please help us get the bill heard early. We want to have a hearing as early as possible. In 2017, it happened really a little too late for there to be movement on this beyond the hearing. So we'd like to, anything you can do to help get the bill a hearing. And insurance, and it was referred to insurance the other day in the House. And we expect it'll likely be referred to Business and Commerce in the Senate. Anything you can do to get the bill heard there early, we'd very much appreciate. Please connect us with anyone who has been impacted. We're always looking to build our base of patient and provider advocates. And as mentioned, I think everyone knows someone who has been affected by this issue. So please help us connect those dots. And of course, when the bill hits the floor, please vote yes. And if you have any questions, this is the last call to action. If you have any questions that come up along the way, or you need additional information, please don't hesitate to reach out to me or another member of our coalition, and we'd be happy to get you the information that you're seeking. Thank you all very, very much for your time. I appreciate it. I know our coalition appreciates it very much. It doesn't look like we have any questions in the Q&A box. I will mention there's going to be a recording of this webinar sent around. So if you missed anything, you'll be able to go back and view it then. Thanks again. I don't think there's anything else. I did want to mention Dr. Finkel asked me to indicate that the patient that he described had quadrupled out-of-pocket cost. So just a final note there, piece of information that we wanted to work in. Patients are being priced out of their medications, their access is being restricted in other ways, and it's causing dramatically negative consequences for them, for our healthcare system, and for our economy. So please help us address that by passing these two pieces of legislation by Representative Lambert and Senator Zaffarini.